Okay, I guess I'm being called to 55-year-old patient or 55-year-old male complaining of chest pain, shortness of breath, and nausea. So I'm going to take BSI precautions, gloves, make sure we have equipment, pen light, stethoscope. Also going to make sure the scene is safe for me, my partner, and also the patient when we're there. So on arrival, hopefully we get met by the patient's family members, who are apparently also there and are the callers. They're going to lead us into the patient. I'm going to have a general outlook of what the atmosphere is like, what the living situation is. Hopefully I can see the patient right away just before touching or approaching the patient. I want to see that he's looking at me, if he's tracking me. I want to get his general appearance. I want to see his skin color, condition, level of consciousness. I also want to get an idea of his hygiene as well. I'm going to introduce myself to the patient. Hello, sir. My name is Andrew. This is my partner, so-and-so. We're with the ambulance. I'm going to introduce myself to the family members as well. I'm going to confirm that this is our patient from family members and the patient as well. Basically, sir, we're just going to do a quick head to toe. I'm going to assess your head, chest, stomach, legs, everything. Just going to do a quick thorough assessment, make sure we don't miss anything. Going to check if he is alert, verbal, or his level of consciousness through ABPU, alert, verbal, pain, or if he's unresponsive. Also going to check his ABCs, airway, see if it's open and clear. I'm going to check his breathing, rhythm, quality, and his circulation. So I'm going to check his peripheral pulses. Going to compare that to his central circulation as well. I'm going to do a quick OPQRST. Going to ask about his chest pain, shortness of breath, and nausea. I want to know when it started, the time, what provokes it, what makes it worse, the quality, if it's a sharp, dull, achy pain. I want to know if it radiates anywhere to the back or down to the stomach or up to the neck. I want to know the severity. I want to rate it out of 1 out of 10, 10 being the worst amount of pain. And also how long he's been having this pain. And I want to make sure he's understanding these questions that I'm asking and what all this means as well. I want to know what he was doing when the pain came about also. Then I want to get once I get my OPQRST, I want to get a sample history, signs and symptoms. So obviously this, allergies, medications, past medical history, his eating habits or last oral intake, and again the events that was leading up to this situation. I want to ask this patient if he's had any about his past medical history, or past cardiac history as well. If he's ever had this situation before, if he's felt the same kind of pain, if he's ever been diagnosed with any kind of cardiac issues before, or if there's anything in his family history as well that has ever presented with cardiac. And then I want to ask if he's had any recent infections, I believe, any pulmonary infections. And then I'm going to start with my head to toe with this patient as well. And so I'm going to start at the head, assess his pupils for if they're pearl, equal, reactive to light. I'm going to move down to the neck, check for any JVP. I'm going to check the trachea, make sure it's midline, make sure there's no tracheal tugging. I want to check his chest. I'm going to check his respiratory rate. I want to check the depth. I want to check his SpO2, his rhythm, quality. And then I want to also, I'm going to palpate the chest as well. I'm going to ask him to hold it, and if there's any change in pain or quality of pain. I'm also going to look for any accessory muscle use. And I'm going to have a listen to his lungs. I'm going to check the apices and bases, and then I'm going to do the 12 points. So I'm going to compare the apices on both sides. I'm going to work my way down from in kind of a Z shape in about 12 different points all the way down to the lobes. I'm also going to listen to the mid-axillary as well. I want to also assess the posterior side for the exact same thing, and work that Z shape to, I believe, the 12 points for listening to the lungs. Then once I've listened to that, I also want to do heart sounds. So I'm going to listen to his S1 sounds, which I'm going to find the manubrium and second intercostal space, right lateral to the sternum. I'm going to listen to the aortic valve there. Then I'm going to do the same thing, second intercostal space on the left side, listening to pulmonic valve. And then I'm going to go down to the third intercostal space. I believe I am listening to the tricuspid valve. And then fourth intercostal is Erb's point. Fifth would be my mitral valve. And I'm going to use my diaphragm, and then I'm going to use the bell to listen for any heart murmurs or anything like that. So that will be my S1 through 4. 1, 2, 3, 4. And then I'm going to move down to the abdomen. I'm going to inspect, look for any emesis or any ecchymosis. I want to see if I can notice any distension or rigidity. Once I've inspected that, I'm going to auscultate it first before I palpate, and I'm going to explain to the patient as I go as well. So I'm going to auscultate the 4 quadrants of the abdomen, listening for at least 5 to 20 seconds for abdominal sounds. And I'm going to palpate the abdomen. If there's any pain, I'm going to palpate away from the pain or the opposite side of the pain. I'm going to go at least 1 to 2 centimeters in depth first, and then if there's no pain there, and if I don't feel anything, I'm going to also look for any distension, rigidity, tenderness upon palpating the abdomen. Along with this, I want to ask him about his bowel movements, if he's noticed any blood in his bowel movements, or how often, what they look like, the quality. I'm going to ask if there's any history of gastroesophageal reflux disease. Then I'm going to, so let's palpate. Move down to his lower extremities. Gonna look for any edema, any pitting edema. I'm gonna see how high it goes. I'm going to press down and see and check for. I'm going to check the depth of that edema as well and see how long it takes for it to return from indentation to normal. I want to check his peripheral pulses as well, and I'm going to check for CMS, his circulation, motor, sensory. I'm going to have him push and pull against my hands. I want to check his rate of motion as well for his extremities. And same with the upper extremity. He's going to check his peripheral pulses, circulation, motor, and sensory. I want to feel his grip as well, get him to squeeze my hands. I'm going to check his fingernails for any clubbing in the fingers. And then we're going to also, this patient, depending on the cardiac of this patient, I'm going to stay here and treat the patient here if I can. I don't want to move him. Obviously, I'm going to take him to a hospital. I Also want to, I'm probably going to be thinking of differential diagnosis as well, along with my assessments. This could be, if it's acute coronary syndrome, depending on the way he's presenting, I'm going to check his ECGs, see if there's any ST elevation or changes or anything like that. So I'm going to see that V1, V2, AVL, AVF. Also, if I just do a 4-lead first as well, if I see any ST, I'm going to do that 12-lead to get a better idea of where that is. And that'll help me determine if we have ACS, or if this is just angina, or if we have left-sided heart failure, and or even AAA, actually. Also, going to reassess this patient. I'm going to treat him. If I'm going to treat him, if this is ACS, I can give him for pain. I'm going to make sure he gets fluids going. I'll want to give him ASA, oxygen, of course. That would have been done in the beginning. And I can give him ASA, nitro, maybe a little fentanyl for just to, if that is needed for minimal pain, Zofran, if I watch the QT prolongation for that nausea. Also going to make him aware of a PCI, and that could take up to an hour and a half or 90 minutes for a PCI to be done with, and I think that's it.